So again, this is not based on any particular randomized thing, but one idea when you're thinking about how am I going to decide between intensive and non-intensive therapy in this person is, have I done enough of my workup? Like Mark said, I definitely think trying to get P53 as early as possible, because that's something where you might want to, even in a fitter person, move to a decitabine-based regimen, for example, or hypomethylating agent, because we know that 7 and 3 is has poor performance in those. Pulling out NPM1. So really there are a percentage of older people who can do very well with NPM1 positive therapy, and those are people where I might say, is there any way I can give them intensive therapy? FLT3, of course, we've got targeted agents. KIT, there's targeted agents. IDH1, now there's targeted agents also. Not for upfront, but just something to have in your mind. I calculate sometimes the TRM, depending on the patient, especially if I'm on the borderline, how am I going to treat this person? I look at their comorbidities using a Charleston, and we don't formally do a geriatric assessment on everyone, but we've just met and we're looking to do a protocol where everybody will get a geriatric assessment beforehand, and then we have some work on muscle building. So then you can say, is this a fit person, is this a frail person, or is this vulnerable? Frail may be somebody who really isn't going to benefit from any treatment at all, or just supportive care. Fit, somebody who you'd want to push for induction therapy. And you want to consider the patient status, you want to consider the disease biology. And it's really, you have to look at both of those before you make a decision. So if you go with intensive therapy, you can do the 7+3. I wanted to briefly bring up the data that's led to the approval of CPX-351 based on Jeff Lancet's study, his large study that he presented at ASCO in 2016, looking at 309 patients in the age group we're talking about. They all had very high-risk disease, secondary or treatment-related, higher-risk cytogenetics. So the patient that I presented would have fit in this category. They randomized people to 7+3 versus the CPX. And there was a small benefit in TRM with the CPX and 31% reduction in the risk of death. Again, I just want to point out, yes, this was approved, and yes, this is an advancement, but this is not a home run. We are still looking at a 9-month median overall survival for these individuals. And this was relatively low. Again, when you're looking at 7 and 3, this is not a very great outcome for the median overall survival for the control arm on this. Again, perhaps because of the higher risk people. CRs, again, not a home run here, and 1-year overall survival of 41%. There was a study published or presented at ASH last year that looked at taking these people to transplant, and they do very well. They do better after transplant than those that were taken to transplant from this arm, maybe because of the depth of the response. We know the cytopenias are longer, giving people an increased risk of infection sometimes with this, and there may be what we don't know is if you have somebody with FLT3 positive disease, how you might combine midostaurin in a regimen like this, I think is still a very open question, or whether or not you need to. What about transplant? So transplant is really something that if you have a fit patient, chronological age shouldn't necessarily mean that they don't go to transplant. We know that, well, we don't know that, but we anticipate that. There's retrospective data published out of the CIBMTR that looked at allotransplant with reduced intensity conditioning. You can see there's really no independent effect of age on clinical outcomes, although the numbers get much smaller. But if you're going to really give induction chemotherapy, if your goal is to try and cure somebody, then you have to think about transplant, and you have to think about how I could safely transplant an older person. This, of course, is a result of the BMT-CTN-0502, a prospective study of reduced intensity transplant in an HLA-matched donor with patients up to the age of 74, published by Steve Devine. Fairly low acute GVHD in this, treatment-related mortality of 15%, but and a 2-year disease-free survival of 42%, and overall survival of 48%. So in the right patient, you need to think about transplant early. You need to get those people typed early. You do not want them to relapse before you can get them into transplant. So again, this is just a very potential decision tree. Some of these early studies we did in a fit person, do they fit the criteria to use CPX? Is there another clinical trial of some kind of either cytotoxic induction therapy or your typical anthracycline-based regimen and HLA for transplant early on, if that's your goal to get them there. And keep them safe so that they're not entering transplant, so you don't ruin their chance for transplant beforehand. In the vulnerable and the frail, of course, clinical trials should always be your first thought because really that's where we can make some progress in these patients. Hypomethylating agents, I'll talk about in a second. Low-dose cytarabine is still used as the standard of care in some institutions. And then now that we have gemtuzumab ozogamycin approved, there is a regimen that was in one of the regimens that's in the approval category for this, uses this as monotherapy. I think it's 6 followed by 3 milligrams per meter squared. And this is also up there, although again, nothing's been compared one to another. So hypomethylating agents, what can you predict for your patient? I think the best data of what you can anticipate using azacitidine is from Gumbre. This is the non-randomized study looking at azacitidine versus either conventional care, intensive therapies, low-dose Ara-C, or best supportive care. It really was physician's choice. This was not a randomized study. The one thing we can pull out of there is that in patients treated with azacitidine with AML, the median overall survival is again in the 10 months range. And this, so they may be living this long, 46% alive at 1 year. There's still a lot of sort of logistical burdens to azacitidine. People are still needing transfusions, at least for the first several. Unless they get a great response, you're not going to get a CR as often with hypomethylating agents. Looking in the single digits for real true CR. So people still need a lot of medical care while they're getting it, which is a bit of a trade-off from the quality of life standpoint. But clinical trial outcomes, I looked 2 days ago, there's 100-something studies using a hypomethylating plus a partner agent. The biggest part is that they are not placebo-controlled. There's a very few of them where it's being randomized where we're actually going to know if there's an improvement when you add that partner agent or not. Other clinical trial options, you may have heard about the BEAT AML trial that's currently open in 6 centers nationally. In this study, patients are diagnosed, they're over the age of 60, diagnosed, their bone marrows are sent, they get a genetic screening, they're assigned by tumor marker. And again, this period of time, 7 days, is also a little bit of a proof of concept that you don't need to rush into giving some of these patients treatment, that you can actually keep them well for 7 days while we can derive this information. Those who are marker positive are going into this, and marker negative going into that, going into a broader acting drug. From what I could find on the internet, this is not a trial we have open at MCW, so I don't know that much. I don't know the nitty-gritty. Currently, they have targeted agents, including an anti-CD200, anti-CD33, an IDH2, and a SYK inhibitor. I'm not sure what they're using for the broad acting drug. The other clinical trial I wanted to plug was one that I'm working on. It's this Intergroup study, S1612. This is going to be a randomized phase 2, phase 3 platform study. We have a single control arm. We have a rolling platform of investigational arms that will roll in. They will be compared against azacitidine as the control. Our first investigational arms will use a combination of aza plus nivolumab, aza plus midostaurin, and then decitabine followed by infusional cytarabine. The phase 2 will be a relatively loose definition. Is it as good at 6-month overall survival as the control arm? If so, it goes to a bit more stringent phase 3 investigation. I'm working on this with Dr. Walther and Megan Othis, and Harry Erba is leading this study. We just passed our central IRB, so this should be open within a month to 6 weeks, we're thinking. It's got very open eligibility. Our idea is to have it as real world as possible, and we are hoping to build in some pretty robust translational, geriatric, and quality of life endpoints. All right, so that's a whirlwind on how I think about older AML. I'm happy to answer any questions, and thank you very much for inviting me.